My name is Elizabeth Howard. I'm an epidemiologist at Ochsner Health. I focus mostly on maternal health research, and my team consists of Brian Kreisman, Shai Xu, and Linning Zhang, and we're going to be discussing the maternal exposure to buprenorphine versus methadone opioid maintenance therapy and risk of neonatal abstinence syndrome. So a little bit of background. So women are at greatest risk of substance use during their reproductive years. You can see in the bottom left figure here that the yellow line represents both men and women who are 25 to 44 years old, and it's only increasing. NAS, which is neonatal abstinence syndrome, is basically infant withdrawal from opioids, and it's also increasing nationally. It can be caused by the pregnant mother taking opioids recreationally or through opioid maintenance therapy. And maintenance therapy during pregnancy is encouraged due to the risk of relapse or overdose in the mother. So the figure on the right shows the rate nationally in the US per 1,000 newborn hospitalizations. So you can see that it's quite different depending on the state. Sadly, my state is very, very high, but on average, it's 5.4 per 1,000 newborn hospitalizations. So to reduce the risk of NAS and other poor maternal health outcomes, pregnant women with opioid use dependence are treated with either methadone or buprenorphine as opioid maintenance therapy. And the literature does suggest that buprenorphine carries less risk of NAS than methadone. However, these studies have been limited by not being able to control for unmeasured confounding, specifically things like severity of an addiction and prescribing preference. So for these reasons, we feel like this topic is well suited for an OMOP network study. So our research question is, does exposure to methadone for maternal opioid maintenance therapy have a different risk of neonatal abstinence syndrome following delivery and up to 1 week postpartum relative to buprenorphine? So our primary objective is to describe the demographic and clinical characteristics of these patients who are being treated for opioid maintenance therapy during pregnancy. And our secondary objective is to describe the risk of neonatal abstinence syndrome in infants following delivery and up to that 1 week postpartum who are exposed to these drugs in utero. I describe it as future because we will only be able to do it once the mother and baby linkage has been completed. So what I'm going to present here are the characterization of both the maternal and infant cohorts. So a lot going on the screen, but on the left-hand side, this is all the methadone target cohort, and then the right side is the buprenorphine comparator cohort. They're similar in a lot of ways. Both cohorts had cohort entry criteria of a condition occurrence of a single live birth and included procedure and drug exposure concepts. You can see the methadone had more concepts related to it than the buprenorphine. Both are exclusive. So if you were in the methadone group, you did not take any buprenorphine during that period, and vice versa. And both were restricted to between 12 and 55 years of age and female gender, which doesn't seem like it should be required, but it turns out data is messy. So the additional cohorts that we looked at for comparison, the first one listed is a comparison cohort for the maternal opioid use disorder cohorts. And basically, it's just all live births, singleton, born to women between 12 and 55. The second one listed is our infant NAS outcome cohort. So that would be a NAS diagnosis with descendants, and that's the concept code there. And you had to be less than a year old. And then we have a comparison for that group, which is infant non-NAS. So basically just no diagnosis of NAS following delivery, which in OMOP language is 0 occurrences between 0 to 7 days, and then an age less than 1. So this is a table showing the patient numbers, the counts at different OMOP institutions. We were lucky enough to have a few different groups run it for us to see. So on the left in the peach color, those are the maternal cohorts that I mentioned, and on the right in the blue are the infant cohorts. Overall, you can see the first three institutions have fairly similar numbers. NAS is, of course, not that common. More common at some institutions than other. Could be just, a linkage problem. And then institution D, we are currently investigating why there are so many buprenorphine mothers. But like I said in the first slide, it does vary greatly between states. So. These are some of the characterization results for the mother's exposure cohorts. So you have your buprenorphine, methadone, and then just all live births. So age, and by the way, this was all run at Johns Hopkins. So all the data I'm presenting from here on out would be just Johns Hopkins data. So age, it was similar with most women delivering between 30 to 34 years of age. Race, both buprenorphine and methadone maintenance therapy cohorts were much more likely to be white than, you can see that here, than the all patients group. Ethnicity, Hispanics were less likely to be in the buprenorphine and methadone cohorts. And then we looked at both depression and anxiety diagnoses and then any pregnancy complication. And both OUD cohorts were much more likely than the birth cohorts to have those diagnoses. So you can see 9, 10, 2.3. As far as delivery outcomes, you can see both the labor and delivery complications were more common. Preterm birth was much more common in the methadone group. Severe maternal mortality was pretty similar between the OUD cohorts, but much larger than percentage than the singleton live birth cohort. And then mortality, which was rare, but proportionally, it was more common in the methadone cohort. Then we wanted to look at some of the most common maternal conditions. So between the groups, and this is a lot of writing, but basically I didn't list the conditions that were related to live birth or other really common gestational age covariates, like things like single live birth, third trimester pregnancy, kind of the stuff you would expect in this cohort. And so the most common for the buprenorphine was substance dependence in mother, same for the methadone. And then mental health disorders and depression were really common in both OUD cohorts. And even mental health disorders was seen as a very common mental health condition in the all singleton live birth cohort, although at a lower percentage. Let's see what else. Then, so let's see. We saw that labor and delivery was complicated by a fetal heart rate anomaly in the buprenorphine cohort, and anemia was more common in the methadone cohort. Procedures, I excluded ultrasounds and routine venipunctures, and so you can see the most common procedures between the groups. As you'd expect, the drug tests and substance use were the highest in these two groups. Immunization administration was common in all groups. Then there was electrocardiogram, ECG done in the methadone group more often than the other groups. But interestingly, drug test also was a very common procedure among all births. These are the baby outcomes. So this is the NAS group, and this is just all babies without NAS who were delivered at Johns Hopkins. You can see that the most common, excuse me, race was white, most in the NAS group compared to the infants without NAS group. They were also less likely to be Hispanic in the NAS group, and gender was fairly even, as you would expect. The most common meds in the NAS group, after excluding like the common ones after birth, like erythromycin and vitamin K, were the following: glucose injections and ampicillin injections, have Pep B, gentamicin, and morphine. Morphine would be the treatment for opioid withdrawal syndrome. So that's more common there. The most common conditions after excluding single live birth and NAS was neonatal jaundice, which was more common in the NAS group. Fetal disorder caused by chemicals, which I'm not exactly sure what's included in that, but followed by respiratory distress syndrome and low birth weight. The most common procedures were radiology related and assistance with respiratory ventilation, and then a vaccination. So mortality, 0 were found in the NAS group for 30-day, but the total mortality, even though again small numbers, you can see that the proportion is higher in the NAS group. So lessons learned, you do need to specify age and gender even when defining pregnancy cohorts, and we definitely wanted to check for totals in the covariates because we, like shown here, they don't always total 100 when you export the data. Then we want to check variation in our estimated counts across institutions. That's really important to investigate if needed as to why you see discrepancies. So our next steps are to identify additional data partners, especially those with a claims database, since morphine and buprenorphine are not administered the same, and or find linked mother-infant data. So we want to complete the meta-analysis for the descriptive analysis of the mood population with these interested partners. And then once the mother-baby linkage is completed, to do a complete population level effect estimation of treatment exposure to both these drugs and then the risk of NAS. So that would be our second objective. So we'd also like to acknowledge a number of people. So these are our data partners that help provide the counts. Special thanks to the NIH Improve initiative for the opportunity. I'm also part of the Southern Center for Maternal Health Equity, which is based in New Orleans. And the OHDSI Maternal Health Data Science Fellowship leaders who helped us specifically with this project are listed.